Today, we're diving into a really powerful healthcare model coming out of northern Ghana. It's a system that's designed to solve a baffling paradox. A country with literally thousands of unemployed nurses, yet millions of people who can't get even the most basic care. We're going to break down how this RN entrepreneur model turns what looks like a national crisis into a sustainable local solution.
So let's start with a question that really gets to the core of this whole thing. We usually think healthcare problems are about not enough doctors or not enough medicine, but what if the real bottleneck, the biggest barrier to getting people care, isn't medical at all? What if it's all about logistics, just getting the right stuff and the right people to the right place at the right time?
To really get this solution, you first have to understand the incredible scale of the problem it's solving. And in Ghana, it is a massive and honestly a completely counterintuitive paradox.
Okay, get this number, 74,000. That's how many trained health workers, mostly nurses, are currently out of a job in Ghana. The government has paid for their education, but now it just can't afford to hire them. This is a huge waste of talent, a massive sunk cost for the entire country. And here's the other side of that paradox. While all those skilled nurses are just sitting around, the doctor-to-patient ratio up in rural northern Ghana can be as bad as one doctor for almost 9,400 people. It's a textbook market failure. You've got this huge supply of skilled people, and you have this desperate demand for their skills, but the two just cannot connect.
So how in the world do you bridge that gap? Well, the Give Basic Needs initiative came up with a pretty radical shift in thinking. What if, instead of waiting for jobs that don't exist, you empower these nurses to create their own jobs?
The core idea is to turn these unemployed nurses into what they call RN entrepreneurs. Instead of getting a salary, they get a one-time medical capital grant. And listen, this is not a handout. It's seed funding. It's venture capital to build, equip, and license their very own private clinic. They go from job seekers to business owners. Now, this model is built on some really smart pillars. That initial grant covers the big startup costs, the capital expenses. But, and this part is absolutely crucial, there's a no-grant train policy. That means the nurse is on the hook for all the day-to-day operational costs. Their income is the profit they make. The community pitches in by providing labor to build the clinic, which creates instant buy-in. And maybe most strategically of all, every clinic is built around an anchor asset, a borehole giving out free, clean water, which guarantees people will show up every single day.
Now, on the surface, this sounds pretty straightforward, right? But look, anyone who's worked in development knows that just dropping a clinic into a village is usually a recipe for disaster. Equipment goes missing, the supply chain breaks down, and pretty soon the whole business just dries up. So, what makes this one different?
Well, the real innovation here, the model's secret sauce, isn't what you can see out there in the village. It's the invisible infrastructure holding the whole thing together.
The success of this whole decentralized network of clinics depends entirely on a centralized hub, the Tamale Command Center. This is the brain of the operation. It's where all the logistics, the oversight, and the real power of the model are managed. And right at the heart of that command center is one incredibly important role, the project coordinator. The source material for this calls this person the air traffic controller for the entire network of clinics. And honestly, that's the perfect metaphor. They aren't just managing one clinic, they are orchestrating dozens of them simultaneously. The project coordinator's job really boils down to two main functions, two pillars that make sure these nurse-led businesses don't just survive, but actually thrive.
The best way to think about it is like this. Pillar 1, grant integrity. That's all about defense. It's about protecting the donor's initial investment. Pillar 2, supply chain leverage. That's all about offense. That's about actively helping the nurse run a profitable, sustainable business.
So grant integrity is all handled with technology. Every single piece of equipment, from a solar panel right down to a microscope, is logged and tracked on a digital platform called ERP Next. From the command center, the project coordinator can remotely audit how that equipment is being used. If a diagnostic kit hasn't been used for weeks, they're going to know about it. This prevents what we politely call asset diversion, which is what happens to so many aid projects.
Okay, now for the second pillar, the offense. This is the real game changer. You see, a single nurse trying to buy medicine is going to pay retail prices, but the project coordinator, they aren't buying for just one nurse. They're pooling the demand for the entire network. This is the economic engine of the model, right here. By buying in bulk, the coordinator gets massive discounts, and those savings are passed straight to the nurses. It acts like an operational subsidy, but it's not a cash handout. It means the nurse can sell medicine at a price the community can actually afford, while still making a healthy profit that becomes their salary. It's a win-win.
And there's more. The command center can see every clinic's inventory levels in real time, so they don't wait for a nurse to call in a panic. They see stock is getting low, and they push a resupply out before it runs out. This prevents the #1 thing that kills patient trust in rural healthcare: walking for hours to a clinic only to be told they have no drugs.
When you actually compare this model to other well-known ones in Africa, like Unjani clinics in South Africa or CFW in Kenya, you can really see its unique strategy. The startup cost is way lower because the villages build the structures themselves. But the real standout feature is what they call the primary anchor. For the health hubs, as you see here, it's clean water. The other models are anchored by things like brand or drug quality, but neither of them ties healthcare directly to a fundamental, daily need like water. That gives these hubs a huge advantage in becoming part of the community fabric.
But of course, no model is perfect. You've got to be realistic and look at the strategic risks that could threaten the whole thing in the long run.
3 big risks really stand out. First is the brain drain. A really successful nurse might just save up their profits and use them to migrate to the UK or Canada. Second, there's seasonality. Farmers have money after a harvest, but not during the lean season, and that creates serious cash flow problems for the clinic. And finally, you can never discount political interference. That's always a risk for successful projects at the community level.
So when you pull the lens back and look at this entire system, what does it all mean for the future of international development and foreign aid? What this model really does, what's so profound about it, is it performs a fundamental paradigm shift. It takes aid out of the world of charity and puts it squarely into the world of venture capital. It stops treating people like passive beneficiaries and starts treating them like active business owners. The end goal here isn't just health, it's economic self-sufficiency.
And that kind of leaves us with a final big question to think about. Maybe the future of effective aid isn't just about giving resources to meet an immediate need. Maybe it's about making smart, strategic investments in untapped human capital, giving people the tools and the systems they need to build their own sustainable local economies from the ground up.